Thanks, Will. It's a pleasure to be here, and I appreciate the opportunity. Thank you for the invitation yesterday. What I'm going to talk about is liver transplantation for metastatic neuroendocrine cancer, which, as you know, occurs with oftentimes with unresectable, large number of metastases throughout the liver. And the question is, can we help these people with liver transplantation? In summary, for my entire presentation, we really don't know if we can help them, and that's kind of the conclusion of all this, and we'll try and get back to that theme from here. You're all very familiar with the natural history of neuroendocrine cancer, so I won't belabor the point, but the aims of treatment are very important. Because what are we trying to accomplish? We're trying to palliate hormonal syndromes for patients with functioning tumors, and that can be done by a multiple number of modalities, including resection and transplantation. And we're also trying to prolong survival. And survival can be prolonged either with surgical resection or debulking procedures, and possibly with liver transplantation. When we look at the number of series that have been presented or published for metastatic neuroendocrine cancer and liver transplantation, they're depicted in this graph, which I owe my gratitude to my colleague and friend David Nagorny, who had it on his computer. But he compiled a number of cases since 1998 up to the present time. And then on the bottom line, you can kind of see that there's been over 200 patients reported in the literature transplanted for metastatic neuroendocrine cancer. Median follow-ups are fairly short at about 37 months. 1-year survival is greater than 85%, which you'd expect with just the 10% perioperative mortality associated with liver transplantation. But 5-year survival is generally about 50% or greater, and disease-free survival is exceedingly rare. Almost all these patients eventually have recurrent disease. And as Lehnert put together back in the late 1990s on a series of transplant patients looking at overall and disease-free survival for patients, 103 patients treated by liver transplantation, he looked at 3 favorable factors: young age, less than 50, primary of the tumor being in the lung or the bowel, and octreotide therapy, and found that for patients that didn't have any favorable prognostic factors, survival was much less than for those that had either 1 or 2 of those factors. However, the key point is we know that survival is okay, but we still don't know if transplantation affords a benefit, because we do not know how these patients would have done without transplantation. We had 2 successful cases in our own meager experience up until about 2000. We had transplanted 2 patients, one for carcinoid and another for a VIPoma, and both did pretty well. And for that reason, decided to go ahead and develop a protocol, which we did in 2002 with predetermined inclusion and exclusion criteria. And our specific aims were to compare efficacy to conventional treatment, and also to prospectively collect our data for retrospective determination of best candidates for transplantation. That's a mouthful, and actually it's a strategic misadventure. Anybody that states this is an aim is just doing something and then trying to find out in retrospect what worked. And as you'll see from our series, we still don't know. There are different strategies to prolong survival if that is indeed what we're trying to do with transplantation. There's the potential for cure. We might want to transplant people early with minimal disease, select those patients with minimal disease. Or should we restrict transplantation to those without hepatic lymph node metastases? A very strict definition, since most of these patients do have regional lymph node metastases. Another strategy to reset the clock would be to delay liver transplantation as long as possible, to take advantage of the good natural history of metastatic neuroendocrine cancer. But then those patients with widespread hepatic disease, likely to die from liver replacement in the near future, to go ahead with transplantation in that group of patients, essentially resetting the clock and giving them another perhaps 5 to 10 years to repopulate the new liver with metastatic disease. There's 2 different strategies. And with those 2 strategies, we did both. We did not pick one, and that was our error. Our selection criteria were histological confirmation of tumor, metastases not amenable to resection or debulking, resection of the primary tumor prior to transplantation, absence of extrahepatic disease except for lymph node metastases, which we would take out with a lymphadenectomy at the time of transplantation and otherwise be a candidate for transplantation. Exclusion criteria included patients with other malignancies, primary rectal carcinoid cancers, which have a poor prognostic outcome, anaplastic carcinoid or poorly differentiated tumors, patients with right heart failure, and pregnant patients, although you'll see something about that a little later. And that we did not exclude patients with prior hepatic resection or debulking or arterial embolization. They were not excluded from transplantation, but rather we continued those practices up until the time of transplantation. Imaging included the usual studies, including an octreotide scan for distant metastases. We repeated our imaging studies at every 4 months while they were awaiting transplantation. Otherwise, it was a standard transplant evaluation with continuation of standard of care, including all chemotherapy, arterial artery embolization, and so forth. We staged our patients operatively prior to transplantation, either with laparoscopy or laparotomy. Laparoscopy to examine the peritoneum in the absence of locally recurrent disease, and either switching to or going directly to laparotomy if we thought there was a need to reassess the primary neuroendocrine tumor site or to resect a primary or locally recurrent disease. And then in these patients, we would observe them for at least 6 months prior to transplantation. Transplantation was generally with a cava-sparing hepatectomy unless the metastases were close to the cava. We did a regional hepatic lymphadenopathy at the time of hepatectomy, and our immunosuppression protocol was our standard tacrolimus, mycophenolic acid, prednisone, tapering to single-agent tacrolimus after 4 months. Our experience from 2002 to 2005 included 24 patients that underwent staging laparoscopy or laparotomy. 21 did not have any extrahepatic disease. 3 did, one of which was resected, and transplantation was performed 3 years later. Another that had a repeat distal pancreatectomy and transplanted 7 months later. And the third that had a recurrence in the pancreas, and we did not go ahead with transplantation. Of the 24 patients, 20 underwent transplantation at the Mayo Clinic, 16 with deceased donors, and 4 with a living donor. One of these patients was an intraoperative death. 2 were transplanted elsewhere. 1 decided against it, and 1 developed extrahepatic metastases precluding transplantation. Of the 20 transplant recipients, 15 were men and 5 were women, and the median age of 47 years. 8 were carcinoid tumors, 12 were pancreatic islet cell cancers, including 3 gastrinomas, a VIPoma, a glucagonoma, and 7 non-functioning tumors, going back to and including the original 2 patients in our series. What we found is in the patients, this is just a list of the procedures that they had. There was a patient that had a primary hepatic carcinoid that did not have any resection prior to transplantation. She had unresectable disease. There was another with carcinoid in the ileum with liver failure and massive ascites. We could not do anything other than resect the primary during the transplant procedure, which was a deviation from our clinical protocol. Although this patient actually died 5 years later from recurrent disease, he would have died within the next several weeks without transplantation, and I actually would consider this patient one of our successes, not a failure. We had 5 reoperations for locally or regionally recurrent disease prior to transplantation, and 5 liver resections prior to transplantation. 8 of our 20 patients had regional hepatic lymph node metastasis, and we could not find any association with that finding and recurrent disease or survival. And also the Ki-67 proliferation index was assessed in 18 explanted livers. It was higher in patients with islet cell versus carcinoid tumors, higher in patients with non-functioning tumors, but the differences were not significant, and again, we could not associate it with recurrence or survival. In short, we've had 7 recurrences with a short follow-up when we published our series with very short follow-up, including an intraoperative death and a very surprising postoperative finding. Since the recurrences occurred both with the carcinoid tumors, which are 3, and the 3 gastrinomas all recurred, as did the 1 glucagonoma. Our overall survival that we reported in 2006 was 90% overall, with disease-free survival of 48% at 4 years. Since then, we've done a few additional transplants and have more appropriate and longer follow-up. We've transplanted 23 patients, including 10 with carcinoid, 9 with islet cells, and 4 although these are islet cell carcinomas, they're unique in that they're either gastrinomas or glucagonomas. All 4 recurred. 3 of the 4 have died, and the 5-year survival is very low. Our overall survival is 76% at 5 years. Disease-free survival is 37%. And looking at the different tumors, the disease-free survival, the patient survivals are fairly similar between the carcinoid and the islet cell tumors, whereas the gastrinomas and the glucagonomas do quite poorly. Disease-free survival, again showing much lower survival for the gastrinoma and glucagonoma patients. And looking at survival after recurrence, which might reflect a bit of immunosuppressive therapy, you can see that between 3 and 4 years, virtually all of these patients die, and the diseases behave the same regardless of the primary etiology of the tumor. Comparing our series to several multi-center trials, including a French series and a U.S. multi-center trial that did not include our patients, you can see that the survival results with these 3 studies are fairly similar for 5 years. The key observations which I think we should share is that liver transplantation is indeed feasible with satisfactory short-term survival. Recurrent disease develops in half of the patients within 3 years. Recurrent disease developed early in all 4 of our patients with gastrinoma or glucagonoma. The progression of the recurrent disease did not seem to us to be adversely affected by immunosuppression, despite the fact that poor survival with recurrent disease was quite low. There were few survivors beyond 3 to 4 years. As far as the efficacy of liver transplantation, though, we do know that it can clearly palliate symptoms for patients with non-functioning tumors, functioning tumors. But as far as the prolongation of life, we're really uncertain. Is there a potential for cure, or should we try and reset the clock? The state of the practice, as I see it, would be that liver transplantation for neuroendocrine cancer alleviates symptoms from functioning neuroendocrine cancers. Recurrence is common, but the indications and optimal timing for transplantation are very ill-defined. There's absence of prioritization in the United States, which precludes wider spread application, and the efficacy remains uncertain, particularly because we do not have any comparison with how these patients would have done without transplantation. In the future, I think we will continue to perform liver transplantation for selected patients. However, we don't know. Should we try and palliate symptoms from patients with functioning tumors? Probably. How about those with absence of extrahepatic disease for unresectable primary tumors? Possibly. Should we transplant patients with early stage disease, particularly younger patients, seeking the potential for cure, or is that unrealistic? I think that it probably is. Or should we consider transplantation for later stage disease when there is life-threatening complications developing from liver replacement? Deceased donor liver allocation for patients with metastatic disease is problematic in the United States. It essentially now requires either the use of a living donor or some type of extended criteria donor liver, and we're using several grafts from familial amyloid patients undergoing combined heart-liver transplantation or liver transplantation alone as domino donation transplantation. Finally, I'd like to share with you, Axel Foss is not able to be with us, and I know he had a mini oral presentation tomorrow, but on the same vein, he has some experience with liver transplantation for metastatic colon and rectal cancer. Since November of 2008, through their protocol, they've transplanted 16 patients. Their median follow-up was quite short at 25 months, ranging from 3 to 38 months. 10 recurrences, and short-term survival at 94%. And he did communicate to me that he wishes that he could be here to talk to us about that experience. Finally, as promised, I wanted to show you my most surprising ultrasound, which was in a 36-year-old female with the primary hepatic carcinoid. The day 1 ultrasound showed a pretty good artery, as we hopefully expect in most of our patients, but it also showed a 13-week fetus. So you have to be aware these patients don't have liver failure, they remain fertile. She was somewhat obese, but for a brief period of time, our survival with liver transplantation for metastatic neuroendocrine cancer was actually greater than 100%, and I don't think you can beat that with anything. Thank you.